Good morning. Together we're live from St. John today, our first Facebook Live. I'm Dr. Regina Druz, Chief of Cardiology, working to bring heart services to the Rockaways, and together with me is Dr. Jinoos Taef, who is Associate Director of our residency program in the Department of Medicine. Good morning, Dr. Taef.
Good morning, Regina. How are you?
Excellent. So today our goal is to help our patients understand a little bit about heart disease and heart disease risk factors, February being American Heart Month. We're doing this as an educational opportunity for our patients to help them understand what they can do for their heart health, and how St. John Episcopal Hospital can actually help them have a healthier heart. Now, Jinoos, you and I know that there are multiple risk factors for heart disease: hypertension, high cholesterol, family history, smoking, obesity, inactivity. The list keeps on growing and growing. From the internal medicine perspective, what do you think is the role of smoking in heart health?
Smoking is a major risk factor for heart diseases, and the chemicals in the tobacco harm our blood cells and also damage the function of our heart and structure and function of blood vessels, and it actually enhances the accumulation of some waxy material in the vessels, which the disease, we call it atherosclerosis. So it causes occlusion of the vessels, blood clots, and in the consequence of that, we can see heart attack, stroke, and so on.
And smoking also exposes patients to what are called heavy metals, things such as cadmium, aluminum, and lead, that have been known to be detrimental from an environmental perspective. Interestingly, one does not need to be an active smoker, unfortunately, to have the bad effects of smoking, but secondhand smoking is also affecting the heart and the blood vessels, making them much more stiff. So if you live as a smoker, make sure that if they do smoke, they smoke away from you, and most importantly, encourage them to quit. We have programs at St. John Episcopal Hospital through the Department of Medicine that can help you to quit smoking. One other factor that I think is also very relevant is stress. What do we think of the impact of stress on heart health?
I think stress affects all of the organs in the body. So there are increasing the heart diseases, increasing the blood pressure issues, hypertension and cholesterol levels. So physical inactivity and overeating, altogether there are major risk factors for heart diseases. While we are in stress, our body releases some hormones like cortisol, which temporarily cause breathing and heart rate to go up, and increase blood pressure, and finally it gives a chronic situation for the body with the side effect of high blood pressure and a lot of load and work on your heart.
Exactly. So stress is unfortunately multifactorial, and the current cardiac literature shows that it's the perception of stress, individuals feeling that they're stressed, that is actually quite detrimental. Through the perception of stress, we activate our immune system that then proceeds on to attack the inner lining of blood vessels called the endothelium, and this is the beginning and also the perpetuation of the atherosclerosis, which is affecting the inner lining of blood vessel and where the coronary plaques are forming. One of the risk factors, of course, that is absolutely probably the number one risk factor for both heart disease and heart failure, unfortunately, is hypertension. And as we know, or you may or may not know, that hypertension guidelines have recently changed, right? So we have a very significant cutoff for what's considered normal blood pressure, which is 120 over 80, or actually less than 80, is now considered normal blood pressure. So we encourage our patients to have their blood pressure checked, and certainly to see us and to understand what lifestyle measures they can potentially implement for themselves, in addition to medications if those are needed, to actually help with these lifestyle factors. Now, patients sometimes ask, interesting questions of us, and I wanted to hear your opinion. Role of red wine consumption in heart disease.
That is an interesting question. because we are hearing that a lot of people are talking of benefits of alcohol, and recently we are hearing that alcohol level consumption level should be zero. So what I can tell is how alcohol or wine affects the cardiovascular diseases needs further research. But right now, American Heart Association does not recommend drinking wine or any other form of alcohol to gain these potential benefits.
So it's indeed a very interesting topic, and I would probably say red wine and coffee keep on sort of coming back and forth in cardiac research and in cardiac discussion. Obviously the benefit of red wine, at least the proposed benefit, was exposure to antioxidant called resveratrol. We don't really have any large clinical studies to support the benefit. We do have a study, just as Dr. Taef alluded, from World Health Organization showing that any level of alcohol exposure could be detrimental. I think the story on alcohol, probably just like a story on caffeine, is yet to be written. I would caution, though, both men and women to significantly limit their alcohol consumption or eliminate it. In general, women should not be using more than a glass of wine per day, and most likely per week would be a better option. Sorry about that. This is clearly my hospital place. And so, and for men, it should be 2 or more. Do avoid binge drinking. We see a lot of patients who binge drink on the weekend. They then present to us having palpitations or a very dangerous condition called atrial fibrillation, which prolongs blood clots and is associated with strokes. We unfortunately also see a lot of patients whose hearts over time got weakened through alcohol use, and they have a condition called a cardiomyopathy. So we actually have a special program here for those patients with heart failure that Dr. Taef and I are working on. So why don't we tell them a little bit about that?
Okay, I think I will bring you summarize the huge effort that has been going on for the last 2 years in St. John's to take care of the heart failure patient with the latest standards. As you know, congestive heart failure affects nearly 5 million people in America, and it is a very complex issue. So in St. John's, we had focused on creating some processes that specially target heart failure patients, as well as making sure that these efforts are benefit for all patients, such as smoking cessation, counseling, comprehensive discharge, instruction, and so on. So we initiated transforming care at the bedside. We flag this heart failure patient as soon as they come to our ED department, and our electronic medical record system helps prompt appropriate orders, which prompts the doctors choose the appropriate medications, diet, activation, education, and special care for heart failure. Meanwhile, we started creating an ideal transition home for patients with heart failure. So this program especially includes patient education, different techniques, special techniques for heart failure patients, follow-ups. We have a team of pharmacy who the next day they call the patients to be sure that the patient has reached his medication and affording the medication, and we individual patient who cannot afford it, we can even present the medication at the bedside for them. And the most important thing is we provide a follow-up visit face-to-face in less than 7 days with the physician to assure that everything is going on.
So this is very important for our patients. Our hospital-initiated GET with the guidelines, which is American Heart Association initiative to improve the health of heart failure patients. Heart failure patients, unfortunately, have a very high mortality. Their chance of dying after initial episode of heart failure admission is approximately 30% in the next year. So it is incredibly important that patients follow up with their physicians, that we do find a cause for heart failure, which there are multiple, and this is what the cardiology services focused on. We provide full spectrum of non-invasive testing and referral for invasive testing, as well as procedures such as defibrillator insertions to help patients with heart failure to survive. And we also make sure that appropriate guideline-directed medical therapy is offered to such patients, as well as clinical and mobile tools for medication adherence and follow-up with their cardiologist. So this is incredibly important for patients to know that coming into the hospital might be a setback, but it's also an opportunity for them to get evidence-based, modern, contemporary care that hopefully will improve their survival and, of course, will improve their quality of life. It's been a massive effort on our part to really do that. Now, one of the common reasons why patients may end up in a heart failure is because patients, of course, may have a heart attack. So it is, incredibly important for patients to understand that heart attack is something that can occur mostly in middle to older age, but sometimes occurs in younger adults. And not uncommonly, patients present with some chest pain symptoms to an internal medicine physician. So, Jinoos, when do you think is a certain age where a patient who may be seeing an internal medicine physician should either ask or inquire if they should see a cardiologist?
Okay, so our recommendation is everybody should have an annual checkup with the primary care doctor and internist, but we usually don't recommend the patient to go for the special cardiology test unless they have symptoms and signs like chest pain. The reason is these unnecessary tests without any symptoms. With this test, we could end up with unnecessary testing leading to unnecessary procedures, a lot of worries and concern for the patient.
And
expense. So the best thing is going to their internal medicine physician annually, and as soon as you have a symptom and sign, we refer you to cardiologist.
And I have to say that in general, our referral system works extremely well. If you have chest pain, shortness of breath, palpitations, or just not feeling well, it is absolutely key to have a primary care doctor who knows you, who can evaluate you and instruct you to go accordingly. We have seen, unfortunately, a lot of such patients come straight to emergency room only to be told that they really don't have a heart condition. And approximately in the country, 70% of all visits to emergency room for chest pain tends to be for conditions that are not due to acute heart issues such as a heart attack. However, it's very important if your symptoms are there, if they're not really going away, that you come under the medical attention. We are going to be bringing a very novel opportunity to Farakuis with our cardiac CT. It's going to launch in mid to late March, and we will be able to provide care to patients with multiple symptoms in non-invasive fashion to let them know whether or not they actually have obstructive coronary artery disease.
Without going to
Without
invasive,
exactly,
to go
for invasive.
non-needed cath.
Correct.
For intermediate to high-risk patients, we can do this test without being very invasive.
Correct. And so we would like our patients to understand that we are here to help them, right? They're not alone. They're here we're a team, and we have their best interest at heart. And for many of them, coming here to St. John recently was an opportunity to actually get their hearts fixed, so to speak. We had quite a few patients who established care, they received procedures, they returned to the activities that they love to do, and restored their quality of life. So some of the things that I'd like to talk about, and maybe Jinoos, you can weigh in on this. What do we think about heart disease inheritance? Is it heritable?
I let you to answer to it.
Yes.
This is it is inheritable. Exactly.
Very interesting.
We have people at age 20 with heart attack issues. We have people who had bypasses at 30 age.
Correct.
And let me just leave it to you to explain how it is.
So it's a enormously interesting question, because we do know that heart disease tends to run in families, and actually this is having heart disease in the first degree relative, whether mom or dad, especially at a young age, below the age of 50, for example, or even below the age of 60, is considered one of the heart disease risk factors. We don't know exactly how this risk factor contributes to the next generation. Right now, there is a lot of interest in genetics, and some of my colleagues at larger universities have identified extraordinary amount of genetic information, close to 6 million genes, that potentially could explain the risk of heart disease down the line in a currently unaffected individual. So the heart disease is very relevant. If you do know that someone in your family has suffered a heart attack or a stroke, they were of a young age, please find out what the circumstances were. Very commonly, this might be an older person who didn't have a healthy lifestyle, but if it's a younger individual, especially your mom or your dad, this is a reason why you should come to medical attention sooner, because we don't necessarily know if this is going to impact you and how it may potentially impact you. But we do have tools to help patients decide what is the relevance of family history in their particular situation.
Okay, at this moment we are getting a question. Okay, so I think my mom had an issue with heart in a very young age. Should I go for stress test?
So, great question, because that's actually what happens to a lot of patients. The stress testing itself is only applicable to what we call obstructive coronary artery disease. This is a situation where coronary arteries, either one or several, are blocked approximately 70% or more, and very commonly this type of a patient may have some symptoms. So the symptoms could be, for example, chest pain or chest pressure when they exercise, when they get upset, when they take stairs or run for a subway. It could be shortness of breath, palpitations, sometimes even passing out. And these symptoms actually are interesting because they're different between different genders. I would say in a patient like this, I would start with blood work, look at the good and bad cholesterol, very specifically cholesterol particles, and I would strongly consider cardiac CT, because cardiac CT will actually help us find what we call non-obstructive coronary artery disease. The patient very likely, unless they have symptoms, will have a normal stress test because disease had not progressed to the category where it's obstructive. And we have actually heard of these cases, sometimes these are celebrity cases, of patients who were in the public eye and passed all their standard cardiac testing, so no obstructive coronary artery disease was found, and then ended up suffering from a cardiac event. And usually that is due to what we call non-obstructive or early heart disease that could progress very rapidly. This is what we call unstable plaque or unstable coronary artery disease. So we encourage you to, again, come to your primary care physician, get the blood test, know about your risk factors, understand whether high blood pressure, smoking, obesity, high cholesterol, and family history are something that are affecting your health trajectory, and seek care to help you to remedy this. Now, one of the things is that we often tell patients, I know you do and I know I do, is that we tell them to exercise, right?
So what about prevention?
Exactly. So what do you think is the best exercise that patients could realistically do for heart health?
Usually the best exercise is aerobic exercise, cardio. For example, running, jogging, biking, whatever that can increase your heart rate and breathing, unless you should not push for it very hard. It shouldn't stop you from talking with people. So we have a standard number for heart rate, but for generally, you do the exercise, the level that increase your heart rate and breathing, and while you can talk with some people. And what is the number of heart rate that we expect?
So in clinical medicine, we usually ask that a patient goes anywhere between 70 to 85% of what's maximally predicted for age. And a quick rule of thumb, it's 220 minus your age, and then you can plug it into your calculator. And let's say you take 2/3 of that, be 70%. That will probably be sufficient. But literature actually shows that any type of exercise, even though it might be brief and not at necessarily moderate intensity, will also be beneficial. The most important part in exercise is consistency. So if a patient if you're happy to just be walking around the neighborhood, and we are in a beautiful neighborhood that, there's a beach, that we cannot see right now because it's snowing, but we're in a beautiful neighborhood with a beach. If you go on a boardwalk, for example, and walk along the beach, and that's your favorite activity, and it's something that being in nature and just walking, you're going to do very well. If you could, of course, increase some intensity if you're walking as tolerated, just as you said, you should be able to carry on a conversation like you and I do without kind of huffing and puffing. But it's wonderful to be able to do various activities. I would encourage patients to also give some consideration to different types of exercises, weight-bearing exercises, yoga, and stretching, which is very important, especially for our older patients. Exercises that bring them into a community group. Maybe it'll be a dance class or some sort of a community event where they can meet others and socialize, because this is very important for patients to be part of the social group, to have peer group that allows them to express themselves and do anything you can. And of course, if you can do more, do more.
Move your body.
Move your body.
And I know that you have a very, very comprehensive approach to the holistic medicine. What do you recommend for diet?
Oh, so this is so this is very, very interesting, and probably I have to tell you that based on my interaction with my colleagues, there is nothing more contentious in the cardiology space than nutritional advice. We had at one of our meetings Dr. Dean Ornish come and talk to us in the course of a lifestyle intensive, and it was standing room only, and and I think the room was divided in their opinions. I'm going to say this. First of all, let's get rid of a couple of myths, right? So myth number one, if you eat fat, you get fat. That is actually not true. If you eat healthy fat in small quantities, you will not get fat, you will actually lose weight, but that has to be done in consultation with a professional, either a physician, nutritionist, or dietitian. What is important to know is if you eat sugar, you will definitely get fat. And unfortunately, sugar is pervasive. It's in sodas and various other foods, especially processed food. Myth number two, if you eat cholesterol, you're going to have high cholesterol. That is also not true. If you eat cholesterol, you're not going to get high cholesterol. You may have some impact on your cholesterol numbers, but eating high cholesterol does not translate into elevated body cholesterol. Your cholesterol is produced internally in your body, and the food is only one of the building blocks, but there are multiple reasons why a person's cholesterol might be elevated. The most important thing is to eat whole foods. The foods that are not in the package, not in the can,
Fresh.
that are fresh. Eat plants, right? Green plants make a nice relationship with one or two green plants. It could be lettuce that you're going to eat for lunch, let's say, or dinner as a salad. It could be kale, it could be spinach. Again, we have patients with multiple medical conditions, and you can't all of a sudden go from having nothing to having buckets of kale or spinach, because potentially may end up getting hurt. But this is a very important paradigm. So if you were to do one thing for yourself today, you would cut out the sugar.
We can help you here.
We can help you
We
here.
have a very expert team that we can help you with the daily menus, daily schedule, breakfast, and get help from us.
Exactly. And we will be establishing a heart failure clinic, actually, one of our specialty clinics.
Mm-hmm.
And part of the heart failure clinic will be nutritional education and nutritional plan for patients to help them derive the most benefit from eating healthfully. Now, many people think that eating healthy means that it's expensive. It's actually much less expensive to eat healthy food, especially if you make it at home, than to buy a bunch of processed foods in a supermarket. Very good. So I think we have.
Another question you have?
Let's see. Is it worse to have high cholesterol or high blood pressure? Is asking one of the patients.
Okay, I can say both are the same. Or both of them are silent, quiet. For the long time, patient doesn't know that the patient has high blood pressure. For a long time, patient doesn't know that bad cholesterol in the body is high. Both of the situation cause multiple damages to the vessels, to the heart, and multi-organ issues like damage to the brain, damage to the heart,
Kidneys.
And all of them is because of these diseases are silent.
So I would agree with you. I would probably say that blood pressure recently, very, very recently, was recognized probably a little bit more, at least subjected to greater scrutiny. Because in November of 2016, with the release of the SPRINT study data and revision of the hypertension guidelines, we have pushed the hypertension threshold much lower. And this is in recognition of the fact that there is nearly a linear relationship between elevated blood pressure and cardiovascular morbidity, which are cardiovascular diseases, and mortality, which is deaths from heart disease. Hypertension continues to be the leading risk factor for congestive heart failure. So this is why hypertension is usually something that we probably should focus on, and there's a lot of screening programs. But I agree, cholesterol metabolism certainly is highly relevant, but the danger of hypertension is that many people have it and don't know about it.
They don't know about it.
They
right.
don't know about it. You know, the cholesterol may come out on the routine blood work that the primary care doctor or cardiologist sends, but many patients do not recognize that they have hypertension. Hypertension at times tends to be a little tricky because a person may actually have a normal blood pressure in doctor's office and then elevated at home, masked hypertension, or they could have what's called white coat hypertension. They see us in our white coats and their blood pressure goes up, but at home they might be all right. So there is a lot of opportunity for prevention, I think, in hypertension and in cholesterol then as well.
Hey, anything else we got here?
Let's see.
Questions?
Questions are, how are heart attacks treated? Is there a good chance of survival? Absolutely. I think it's very important for patients to know that heart attacks are treated extremely well in contemporary era. We have an opportunity to transfer our patients for direct invasive angiography fairly rapidly from St. John Episcopal Hospital. So if you have oppressive chest pain or shortness of breath and are feeling not well, please don't delay. You may not be able to reach your doctor, but at that point, being in the emergency room may actually prove to be life-saving. I want to take just a little bit of time to go just to touch upon that we're recognizing right now how different the pathophysiology is between men and women, and the fact that women very often present with less specific complaints. One of my patients, for example, went into the hospital because she was extremely tired, and shortly after arriving there was found to have large anterior myocardial infarction and went into cardiac arrest. If it wasn't her presentation to the emergency room, she would not have survived. So it is important to understand that symptoms differ between genders. There are different types of cardiac disease, both structural and sometimes even ischemic between different genders. So it's important for patients to know that medical attention is required. Don't ignore your symptoms. I think establish a good relationship with internal medicine physician, and we work as a team to keep your heart healthy and to bring some spring to your step, right?
And always remember, prevention is the key.
That's right,
Prevention is the key. As soon as you understand your body and you take care of your body and you go to your routine checkups with the primary care, you will prevent a lot of things in the future.
Very good. So what would you say, Jinoos, as we're wrapping up, if patients who are listening to us who do not have a relationship with our hospital right now, what is the best way for them to get to know some of the internal medicine doctors and establish care and come into kind of our care community?
We are in very close relationship with our community. We have multiple clinics around here. All of them are affiliated to St. John's Episcopal Hospital that are helping. We have medical record that they talk with each other so we can understand what's happening there and here, and and we refer to all kind of specialists in the area. There's no sending patient too far. Everything is available in this hospital and satellite clinics. So I encourage everybody to look at our sites and find our addresses and locations, and we accept walk-ins, and we have all of specialties with very good specialist doctors here in St. John's.
And I agree. We run our cardiology outpatient clinic on the 5th floor. It's in the main hospital building. Whether you were discharged from St. John Episcopal Hospital or another institution, we run clinic actually 3 times a week. If you happen to need to walk in, you can actually do that. We provide full range of services, and we always discuss with patients if they need to go elsewhere for more advanced procedures, but we find that close to 90% of the time we're able to meet their needs here. Patients love coming to our clinic. They feel that they're getting better. They get a lot of attention, and I think we're making a difference for the Rockaway community.
Exactly. Huge difference.
Huge difference.
Okay. I don't think we have any other questions.
No.
Coming. Okay.
Thank you, Dr.
Thank
Taef.
you.
It was fun.
Okay, waiting for you.